In this video, we'll cover everything you need to know about arrhythmias in a fast and easy way, from atrial fibrillation to ventricular tachycardia, and how to recognize them quickly. Arrhythmias are simply abnormal heart rhythms. Some are slow, some are fast, and some are irregular. To make sense of them, we divide them into two major groups, bradyarrhythmias and tachyarrhythmias. Brief description. Arrhythmias are disorders of cardiac rate, rhythm, and conduction. Bradyarrhythmias include sinus bradycardia, sinus pauses, and atrioventricular blocks. The tachyarrhythmias can further be classified into supraventricular and ventricular arrhythmias, based on their site of origin. Supraventricular tachyarrhythmias includes atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, and multifocal atrial tachycardia. Ventricular tachyarrhythmias include ventricular tachycardia and ventricular fibrillation. The etiologies for arrhythmias: structural heart disease, valvular heart disease, cardiomyopathies, coronary artery disease, thyrotoxicosis, electrolyte abnormalities, ingestion of stimulants, side effects of some medicines, digoxin, antiarrhythmic medicines. Clinical features of arrhythmias in general include palpitation, shortness of breath, dizziness/syncope, sensation of a pause in the heartbeat, chest discomfort that mimics symptoms of myocardial ischemia, angina, development of heart failure or decompensation of previously existing heart failure, sudden death. Diagnosis: ECG is the mainstay of diagnosis. Other investigations like echocardiography, chest X-ray, thyroid function test, blood count, electrolytes should be guided by clinical data. Prior to treatment of any suspected arrhythmia, the diagnosis should be confirmed with ECG. It is dangerous to give any antiarrhythmic medicine without doing ECG. Tachyarrhythmias, supraventricular tachyarrhythmias, paroxysmal supraventricular tachycardia. Brief description. Paroxysmal supraventricular tachycardia, PSVT, is an intermittent narrow complex tachyarrhythmia other than AF, atrial flutter, and MAT, multifocal atrial tachycardia. PSVT usually occurs in individuals without underlying structural heart disease. ECG shows regular narrow QRS tachycardia. P-wave may be seen preceding or following or superimposed on QRS complex or may not be seen. Treatment. Objectives of therapy include control ventricular rate, identify and treat the cause, identify, prevent, and treat precipitating factors, non-pharmacologic vagal maneuvers. Maneuvers which increase vagal activity can terminate episodes of PSVT. ECG and blood pressure monitoring are required during the procedure. Carotid sinus massage, supine position with the neck extended. The carotid sinus is located inferior to the angle of the jaw at the level of the thyroid cartilage. Steady pressure is applied to one carotid sinus for 5 to 10 seconds. If no response, repeat it in the contralateral side after 1 to 2 minutes. Note: carotid massage should not be attempted in patients with carotid bruit/stenosis or ischemic stroke. Both carotid sinuses should never be massaged simultaneously. Valsalva maneuver. While in the supine position, the patient is instructed to exhale forcefully against a closed glottis with closed mouth and nose for 10 seconds. Adequacy indicated by neck vein distension and increased tone in the abdominal wall muscles. Synchronized electrical cardioversion. Required rarely for hemodynamically unstable patients. The energy needed is 150 to 200 joules for monophasic defibrillators. Pharmacologic. Termination of acute episode. First line, adenosine, IV, very rapidly, over 1 to 2 seconds. Initial, 6 milligrams. If not effective within 1 to 2 minutes, 12 milligrams may be given. May repeat 12 milligrams bolus if needed. Follow each dose with 20 milliliters, very rapid normal saline flush. Alternatives: metoprolol, IV, 2.5 to 5 milligrams every 2 to 5 minutes. Maximum total dose, 15 milligrams over a 10 to 15 minute period. or verapamil, IV 2.5 to 5 mg over 2 minutes. Second dose of 5 to 10 mg may be given after 15 to 30 minutes. Maximum total dose, 20 to 30 mg, or digoxin, 0.5 to 1 mg IV over a period of 10 to 15 minutes, followed by 0.25 mg every 2 to 4 hours, with a total dose less than 1.5 mg within 24-hour period. Prevention of recurrence, chronic therapy. First line, metoprolol succinate, extended release, 25 to 200 mg per day, PO, or atenolol, 25 to 100 mg per day, PO, or propranolol, 10 to 40 mg PO 3 to 4 times daily. Alternatives, verapamil, immediate release 40 to 120 mg, PO/TID, or extended release 180 to 360 mg per day. Atrial fibrillation and flutter. Brief description.
Your heart can beat chaotically without you even noticing. This is atrial fibrillation, where the upper chambers of the heart quiver irregularly, sending mixed signals to the ventricles.
Atrial fibrillation, AFib. Marked by disorganized, rapid, and irregular atrial activation. Results in an irregular ventricular response. Ventricular rate is usually rapid. ECG characteristics.
On the ECG, AFib shows no distinct P waves and an irregular ventricular response. The heartbeat is unpredictable and often rapid.
Lack of P waves. Irregular ventricular response. Narrow QRS. Atrial flutter, AFL. Characterized by a regular rapid atrial rate of 260 to 300 beats per minute. Usually results in a regular ventricular response in a 2-to-1 ratio, heart rate, 130 to 150 beats per minute. Ventricular response can sometimes be 3-to-1, 4-to-1, irregular, or rarely 1-to-1. ECG characteristics. Sawtooth appearance of the baseline, mainly on inferior leads. 2, 3, AVF. Rapid, regular, and narrow QRS.
Atrial flutter, on the other hand, is more organized. The atria beat rapidly, but in a regular rhythm, creating a predictable pattern. Its hallmark is the sawtooth ECG waveform, usually visible in leads 2, 3, and AVF. Ventricular response is typically regular, often in a 2-to-1 ratio. Treatment for both rhythms focuses on controlling heart rate, preventing stroke, and addressing underlying causes. Options include medications like beta blockers and anticoagulants, or cardioversion if the rhythm is unstable.
Treatment. The management of AFib and AFL are the same. Objectives of treatment: controlling ventricular rate, prevention of thromboembolic events, identification and treatment of the cause, identification, prevention, and treatment of precipitating factors, non-pharmacologic, avoid stimulants, e.g., caffeine, CAT, and alcohol intake. Immediate electrical cardioversion. Indicated for hemodynamic instability, cardiogenic shock, due to a rapid ventricular rate. If hypotension occurs at ventricular rate less than 130 beats per minute, investigate other causes. Energy, usually 100 to 200 joules, must be synchronized. Pharmacologic. Acute ventricular rate control, first line, metoprolol, 2.5 to 5 mg IV over 3 to 5 minutes, up to a maximum total dose of 15 mg over 10 to 15 minutes. Alternative. Digoxin, 0.25 mg IV Q2H until 1 mg total. Note. Digoxin is the first line if AFib is associated with severe left ventricular LV dysfunction. Chronic ventricular rate control, first line, metoprolol, preferred beta blocker in patients with heart failure and depressed LV systolic function. Immediate release, 25 to 100 mg twice daily. Extended release, 25 to 200 mg per day. Or atenolol, 25 to 100 mg PO daily. Alternatives. Digoxin 0.125 to 0.25 mg PO daily. Can be added to a beta blocker when rate control is suboptimal. Preferred agent when heart failure due to LV systolic dysfunction is not well controlled. Or verapamil, 40 to 80 milligrams PO, 2 to 3 times daily. Anticoagulation to prevent cardioembolic cerebrovascular accident, CVA. Risk stratification, CHA2DS2-VASC or CHADS VASC score. Used to estimate annual stroke risk. 1 point each for heart failure, HTN, age 65 to 74, diabetes, female sex, vascular disease. 2 points each for age greater than 75, history of CVA. Indication: anticoagulation is generally indicated for scores greater than 1, unless high bleeding risk. Choice of anticoagulant: warfarin only, for patients with mechanical valves, mitral valvular disease, or ventricular assist devices. Direct oral anticoagulants, DOACs, can be used for other patients. Include factor XR inhibitors, apixaban, rivaroxaban, edoxaban, and direct thrombin inhibitors, dabigatran. Do not require laboratory monitoring. Dose adjustment required for renal failure, elderly, low body weight, and high bleeding risk. Warfarin requires mandatory INR monitoring, goal INR 2.0-3.0. Starting dose: 2.5 to 5 milligrams per day, titrated to goal INR. Goal is to maintain time in therapeutic range, TTR, above 70%. Bleeding risk assessment: a discussion regarding anticoagulation must include an assessment of bleeding risk using the HAS-BLED score and shared decision-making. HAS-BLED score assesses hypertension, abnormal renal/liver function, stroke, bleeding history, labile INR, elderly, drugs/alcohol use. Selection: individualize the choice, warfarin or rivaroxaban, based on risk factors, cost, tolerability, patient preference, potential for drug interactions, and TTR history if taking warfarin. Ventricular tachycardia. Brief description: ventricular tachycardias are wide QRS tachyarrhythmias that originate in the myocardium. They are commonly associated with some form of structural heart disease. Clinical significance: malignant, potentially lethal arrhythmias, sustained ventricular tachycardia (VT) and ventricular fibrillation, non-sustained, hemodynamically tolerated arrhythmias, premature ventricular contractions (PVCs), non-sustained ventricular tachycardia (NSVT), and accelerated idioventricular rhythm (AIVR). A ventricular tachycardia which stays for more than 30 seconds is labeled sustained. All wide QRS greater than 120 ms, tachycardias are considered and treated as ventricular tachyarrhythmias until proved otherwise. Treatment. Objectives of treatment: prevent degeneration of ventricular tachycardia to ventricular fibrillation. Reverse cardiac arrest. Non-pharmacologic, CPR should be provided to patients with sustained VT with cardiac arrest. The victim is unresponsive, pulseless, and not breathing. O2 via face mask or nasal catheter. Continuous ECG monitor. Suction device and endotracheal intubation set should be ready. Correct electrolyte disorders. Reassure patients with non-sustained ventricular tachycardia. Defibrillation, DC cardioversion. Sustained polymorphic VT, ventricular flutter or ventricular fibrillation. Emergency defibrillation, without synchronization, with greater than 200 joules, monophasic, increase the energy to the maximum if arrhythmia persists. Sustained monomorphic VT, synchronized with greater than 200 joules, monophasic. Note: if the hemodynamic status allows, conscious sedation should be provided. DC cardioversion is first-line therapy for sustained wide QRS tachycardias. Pharmacologic treatment may be an acceptable option in hemodynamically stable monomorphic VT with no heart failure. Pharmacologic. First line, intravenous amiodarone. Stable VT regimen. Step 1, 150 mg over first 10 minutes, dilute in 100 ml D5W. Step 2, 360 mg over next 6 hours, dilute 500 ml D5W 1 mg per minute. Step 3, 540 mg, dilute in 500 to 1000 ml D5W, over next 18 hours, 0.5 mg minute. Pulseless VT, cardiac arrest, regimen, if unresponsive to defibrillation attempts and CPR. Amiodarone, IV push, 300 mg, undiluted. If VT or VF recurs, administer supplemental dose of 150 mg and continue CPR. Alternative, intravenous lidocaine, both stable VT and pulseless VT, cardiac arrest regimen. Lidocaine, IV, 1 to 1.5 milligrams per kilogram. Repeat with 0.5 to 0.75 milligrams per kilogram every 5 to 10 minutes if no response. Maximum cumulative dose, 3 milligrams per kilogram. Follow with continuous infusion of 1 to 4 milligrams per minute. Preparation for continuous infusion. 2 grams of lidocaine, 250 milliliters D5W. Rate of infusion. 1 milligram per minute equals 7.5 milliliters per hour. 2 milligrams per minute equals 15 milliliters per hour. 3 milligrams per minute equals 22.5 milliliters per hour. 4 milligrams per minute equals 30 milliliters. Prevention of recurrence. Non-pharmacologic. Standard treatment of the underlying cause is the mainstay of treatment for preventing recurrent VT, e.g., treatment of acute coronary syndrome. Correct precipitating causes, e.g., hypoxia, hypo/hyperkalemia, acidosis, pulmonary embolism. Discontinue arrhythmogenic medicines, digoxin, antiarrhythmic medicines. Pharmacologic. First line, amiodarone, PO, 800 to 1,600 milligrams per day in 2 divided doses for 1 to 3 weeks. When adequate arrhythmia control is achieved, decrease to 600 to 800 milligrams per day in 1 to 2 doses for 1 month. Maintenance, 400 milligrams per day. Alternative or additional to amiodarone, beta blockers, metoprolol, extended release, PO, 25 to 200 milligrams per day, or atenolol, 25 to 100 milligrams daily. Refer the patient to next care delivery after stabilization is strongly recommended. Bradycardia, Bradyarrhythmia. Brief description. AV block describes a delay/block of atrial impulses at the atrioventricular node of varying severity. When severe, it results in symptomatic bradycardia, which can manifest as easy fatigability, heart failure, syncope, seizures, and bradycardia-associated ventricular tachycardias. It is caused by structural heart diseases, mainly ischemic heart disease, cardiomyopathies, congenital heart disease, medicines, beta blockers, verapamil, digoxin, electrolyte abnormalities, hypothyroidism, and cardiac surgery. ECG is the diagnostic of AV block. Treatment. Look for reversible causes and act accordingly. Symptomatic bradycardia should be referred to the next healthcare facility for cardiologist evaluation. And that wraps up our overview of arrhythmias. Knowing these heart rhythms can help you recognize emergencies and act quickly. If you found this helpful, hit like, share with others, and subscribe for more quick and easy medical explanations. See you in the next video.